Imagine a ticking time bomb inside your chest. But the timer isn't set for 10 minutes or even 10 days. It is set for 40 years.
Yeah, 40 years. It's a profound medical and honestly epidemiological challenge. We're dealing with an industrial legacy that continues to cast a very long, very dark shadow over global health.
Today, we are looking at a disease that is technically entirely preventable, yet its incidence is still rising. Welcome to a custom-tailored deep dive into the European Society for Medical Oncology, or ESMO Clinical Practice Guidelines for Malignant Pleural Mesothelioma.
Right. This is a dense, highly technical document, but it essentially serves as the gold standard consensus for oncologists worldwide.
Exactly. And our mission today is to extract the most critical, up-to-date insights from these pages. So whether you're prepping for a clinical meeting, catching up on thoracic oncology, or, you're just intensely curious about how modern medicine tackles its most elusive adversaries, we have you covered.
And we should really look at this document as a battlefield map. The guidelines show us exactly how the medical community's understanding of this disease is evolving. It's literally shifting beneath our feet as new data comes in.
Okay, let's unpack this, because before we get into the really complex treatments, we have to understand why a malignant pleural mesothelioma, or MPM, is still such a massive issue today.
Right.
Because, as we mentioned, it's directly and unequivocally linked to asbestos exposure.
Yeah, the World Health Organization classifies MPM as directly attributable to all types of asbestos. When microscopic asbestos fibers are inhaled, they don't just, stay in the lungs.
They migrate, right?
Exactly. They are sharp, jagged little minerals that can work their way out to the pleura. That's the thin, double-layered membrane that surrounds the lungs and lines the chest cavity.
And the body just can't break them down. It's essentially rock.
Precisely. Your immune cells try to engulf and destroy these fibers. But because asbestos is this tough mineral, the immune cells die trying.
Oh.
Yeah, and this sets off a perpetual cycle of chronic inflammation, tissue damage, and eventually genetic mutation. And what's truly terrifying is the timeline here.
The 40-year timer.
Exactly. There is a 40-year lag time between that initial asbestos exposure and the presentation of cancer symptoms.
40 years, which, that completely explains the public health crisis we're in. We all know asbestos is dangerous. It's banned in 67 countries.
But it is not banned everywhere.
Right. Usage is still incredibly high in places like Central Asia. And even in the United States, there are usage restrictions, but there isn't a total absolute ban.
Which means even in nations that aggressively regulated asbestos back in the 1980s, the incidence of mesothelioma is still climbing right now.
Because of that lag.
Yeah. The median age at diagnosis is 76 years old. We are currently seeing the crest of the wave from exposures that happened in the 1970s and 80s.
So if we know exactly what causes it, and we know the demographic, people who worked in shipyards, construction, or manufacturing decades ago, let me push back on this. Why don't we just screen them all? Like, catch it early before it spreads?
What's fascinating here is that the ESMO guidelines explicitly recommend against routine screening for people with a history of asbestos exposure.
Wait, really? Why wouldn't we want to look for it?
Because early-stage MPM is vanishingly hard to detect, and screening just hasn't been shown to decrease mortality. The symptoms take months to develop, and they are incredibly vague.
Like what kind of symptoms?
Well, a patient might come in with dyspnea, which is just shortness of breath, maybe some chest pain, or unexplained weight loss.
Those symptoms mimic dozens of other much more common conditions.
Exactly.
But couldn't a standard chest x-ray spot a tumor on the lung lining if we know they worked with asbestos?
Usually no. A hallmark of this disease is pleural effusion. That's a massive buildup of fluid in that space between the lung and the chest wall.
Oh, okay.
And that dense fluid literally masks the small, flat, malignant lesions on the pleura. On a plain x-ray, the fluid just looks like a giant white cloud. You cannot see the cancer hiding underneath it.
So you have to upgrade your imaging. I saw the guidelines mention needing a contrast-enhanced CT scan of the chest and the upper abdomen just to get a clear look.
Yes, that's the standard workup.
But say you see something suspicious on that CT. Can't we just do what we do for other conditions and, draw some blood? Look for a tumor marker.
You can look, but the circulating blood markers we currently have just aren't reliable enough. The document discusses markers like SUFFER 21.1 and Fibulin 3, but their sensitivity and specificity are simply too low to definitively diagnose mesothelioma.
But there is one blood marker mentioned that actually is useful, though in a completely backward way, right? Carcinoembryonic antigen, or CEA.
Yes, CEA is utilized as a negative marker.
Can you explain how a negative marker works for the listener? Because that's a bit counterintuitive.
Sure, so if a patient has fluid in their chest and a pleural mass, the doctors need to figure out if it's mesothelioma or if it's a completely different type of cancer that is spread to the lung lining, like an adenocarcinoma.
Or like from the lung itself or the breast.
Exactly. Adenocarcinomas are cancers that start in glandular tissues, and they frequently elevate CEA levels in the blood.
Okay.
But mesothelioma almost never does. So if a patient's CEA levels are high, it essentially rules out mesothelioma and points the diagnostic team in a totally different direction.
That is wild. Blood tests fail to find it, x-rays fail to see it, so to actually confirm the diagnosis, doctors have to go in and get physical tissue.
They do.
But the guidelines say even that is a minefield. You can't just stick a needle in and draw out some of that pleural fluid to look at the floating cells.
Well, looking at floating cells in the fluid is called cytology. And while it's minimally invasive, it yields a very high rate of false negatives.
Why is that?
Because the malignant cells are firmly rooted in the fibrous tissue of the pleura. They aren't always shedding freely into the fluid.
Which forces doctors to perform a thoracoscopy. They actually have to insert a camera and instruments directly into the chest cavity.
Yes, and the guidelines stress they need deep biopsies from at least 3 different distant sites inside the chest.
3 different sites. That sounds intense.
They need a robust sample. Because distinguishing mesothelioma cells from completely benign, reactive mesothelial cells is honestly one of the hardest jobs in pathology.
And that difficulty leads us into the microscopic detective work, which was one of the most fascinating sections to me. The pathology.
It's incredibly complex.
Because normal mesothelial cells get inflamed and look weird all the time, right?
They do. In response to infection or trauma, benign cells undergo reactive changes that make them look incredibly suspicious under a microscope.
So it's hard to tell if it's just angry tissue or actual cancer.
For decades, pathologists really struggled to draw the line between extreme inflammation and early-stage cancer. In fact, it was so difficult that only recently, in the 2021 WHO classification update, did they officially introduce a category called mesothelioma in situ.
Mesothelioma in situ, meaning the cancer is localized, it hasn't invaded deep into the tissue yet.
Correct. It is the absolute earliest stage. But because it looks almost identical to benign cellular weirdness, you cannot diagnose it just by looking at the shape of the cells.
You have to look at the genetics.
Exactly. You have to use a technique called immunohistochemistry, or IHC.
So how does IHC actually work to tell them apart?
Immunohistochemistry is a process where pathologists use specially designed antibodies that bind to specific proteins in a tissue sample. They apply a chemical stain to the slide.
Okay, and then what happens?
If the protein is present in the cell, the stain turns a specific color. If the protein is missing, the cell doesn't change color.
And here's where it gets really interesting. When I was reading the sources, my mind was blown by what they are actually looking for.
The loss of expression.
Yes, they aren't looking for a mutated hyperactive cancer gene that is suddenly causing chaos. They are looking for something that is gone. It's like identifying a thief not by catching them on a security camera, but by walking into an art gallery and noticing a very specific painting is missing from the wall.
That is a brilliant analogy. And the specific missing paintings depend on the subtype of the cancer.
Right, there are a few types.
In the epithelioid subtype of mesothelioma, which is the most common and generally has a slightly better prognosis, pathologists stain the tissue to look for a protein called BAP1. Exactly. If the cell fails to stain, meaning the BAP1 gene has been lost, that is a definitive hallmark of malignancy.
And what about the more aggressive subtypes? What are they looking for there?
In the sarcomatoid subtype, which is much more aggressive, they look for the loss of a different gene called CDKN2A.
Okay.
But because detecting that specific loss can be technically difficult, pathologists often use IHC to look for the loss of a protein called MTAP as a surrogate marker.
Wait, why MTP?
Because the MTK gene is located right next door to CDKN2A on the chromosome. They are so close together that if a genetic deletion wipes out CDKN2A, it almost always takes MTP with it.
Oh, guilt by association, or, well, disappearance by association.
Precisely. So if the MTTP protein is missing when they stain the slide, they know the critical CDKN2A gene is gone too.
So what does this all mean for the patient? Let's say we've done the surgery, we stain the slides, we know the exact genetic subtype. What is the next step?
Staging. Before anyone can talk about a treatment plan, You have to know exactly how far the cancer has spread using the TNM staging system.
Break down TNM for us. What do those letters actually track?
T stands for tumor. That's how large the primary tumor is and how deeply it has invaded local tissues. N stands for nodes, whether the cancer has spread to nearby lymph nodes. And M stands for metastasis, whether the cancer has spread to distant organs.
And the ESMO guidelines outline some significant shifts in the 8th edition of this staging system, specifically regarding the lymph nodes.
Yes. Historically, oncologists placed a lot of prognostic weight on exactly which lymph nodes were involved.
Like how far down the chain the cancer had traveled.
Right. But the latest data shows that in mesothelioma, the survival differences between having no lymph node involvement, which is N0, and having local lymph node involvement N1 or N2 aren't as clear-cut as they are in other cancers.
Why is that? Why doesn't the node status matter as much?
Because mesothelioma doesn't form a neat, single sphere like a typical lung cancer. It spreads like a rind along the lining of the chest cavity. Its growth pattern is diffuse.
Got it.
Additionally, the new guidelines note that if the cancer reaches lymph nodes on the opposite side of the chest, the contralateral nodes, that is now classified as N2 disease.
Which means the preoperative imaging has to be incredibly precise. You can't just rely on that initial CT scan we talked about earlier.
Exactly. If a patient is being considered for radical surgery, the guidelines mandate highly specific imaging, particularly a PPCT scan, to rule out any distant spread.
Because surgery is such a massive undertaking.
It is. Putting a patient through the immense physiological trauma of mesothelioma surgery when the cancer is already seated in distant organs offers absolutely no survival benefit. It just causes immense unnecessary harm.
Which brings us to a massive counterintuitive pivot in the guidelines, the surgical shift. Because once you confirm it hasn't spread to distant organs, the immediate question is, can we cut it out?
And this is where the philosophy of less is more has completely taken over the field. For decades, the holy grail for surgical candidates was macroscopic complete resection, or MCR.
Meaning getting every single visible piece of the tumor out of the chest.
Yes, and the historical standard for achieving that was a brutal maximalist surgery called extrapleural pneumonectomy, or EPP.
Yeah, I read the description of EPP in the sources, and the sheer scale of the operation is staggering.
It's immense.
It involves opening the chest and removing the entire lung, the pleural lining, the pericardium, which is the sac around the heart and half of the diaphragm, all in one piece. En bloc.
It was the ultimate scorched earth approach to cancer surgery. The underlying logic was total eradication.
But wait, let me push back here. From a pure brute force physical standpoint, if mesothelioma coats the lung and the chest wall like a thick rind, wouldn't taking the whole lung out be the safest bet to ensure you actually got all the cancer cells?
You would think so. It makes perfect intuitive sense, which is why it was the standard of care for so long. But in medicine, physiology often overrides anatomical logic.
What do the data show?
The data told a very different story. The sheer physiological trauma of removing an entire lung, the massive hit to the patient's cardiopulmonary reserve, entirely outweighs the perceived oncological benefit of the wider resection.
So the cure was becoming as deadly as the disease?
Unfortunately, yes. Which is why the ESMO guidelines now explicitly state that a different procedure called extended pleural decortication, or EPD, is the preferred surgery.
And EPD spares the lung. The surgeons essentially work to peel the cancerous rind off the lung, the heart, and the chest wall, leaving the organs themselves intact.
Correct. It's a highly meticulous peeling process, and the numbers backing this shift are undeniable. The guidelines cite a massive systematic review of 11,145 patients comparing the lung-sparing EPD to the total removal EPP.
And what were the survival differences?
With the lung-sparing surgery, perioperative mortality dropped to 2.9%. With the total lung removal, mortality was 6.8%.
That's a huge difference.
And the complication rates are even more striking. The morbidity, the rate of serious surgical complications plummeted from an astonishing 62% with EPP down to 27.9% with the lung-sparing EPD.
Wow. Over half the patients who had their lung removed were suffering severe, life-altering complications.
Yes. And here is the ultimate data point. Overall, survival between the two procedures was comparable.
Really?
Yes. Sparing the lung did not shorten the patient's lives compared to removing it, but it vastly improved their ability to actually recover and tolerate further treatments. EPP is now rarely performed. It's reserved only for highly selected patients in specialized high-volume centers.
For the patients who simply aren't candidates for these massive radical surgeries, maybe because of their age or their heart health, the guidelines outline palliative surgical options. And this is all about quality of life.
Exactly, symptom management.
Right. So if a patient is drowning in pleural fluid, the top choice is a procedure called talc powderage. How does spraying talc into the chest help?
It utilizes the body's own inflammatory response. The surgeon uses a thoracoscope to blow sterile, medical-grade talc powder into the chest cavity.
Okay.
The talc severely irritates the pleural lining, causing massive inflammation. As it heals, the lung essentially scars and glues itself to the chest wall.
Gluing it shut.
This process, called pleurodesis, obliterates the empty space so fluid can no longer accumulate and crush the lung.
And what if the tumor has grown so thick that it forms a hard shell, trapping the lung so it can't expand to meet the chest wall?
In cases of an entrapped lung, gluing won't work. The lung simply can't reach the wall. So the guidelines recommend indwelling pleural catheters.
What are those?
These are flexible tubes left in the chest that patients can actually manage at home. They drain the fluid themselves to relieve the breathlessness whenever they need to.
Speaking of treatments and the physical realities of this disease, we have to talk about the radiotherapy myth, because this perfectly illustrates how medical science corrects itself.
Yes, the tract irradiation.
Right. For decades, after a doctor would stick a needle or a drainage tube into a mesothelioma patient's chest, they would routinely blast the entry tract on the skin with radiation.
Prophylactic tract irradiation.
Now, let me push back on why they stopped doing this, because the fear makes total sense. You pull a hollow needle out of a tumor, you are physically dragging live cancer cells through healthy chest wall muscle and skin. Physics dictates those cells are going to seed there and grow. Why wouldn't we zap that tract with radiation to kill them?
Because while the mechanical theory of seeding is valid, and patients did sometimes develop very painful skin metastases at those biopsy sites, two massive modern trials, the SMART trial and the PIT trial, proved that the radiation wasn't actually stopping it.
Wait, the radiation just didn't work?
It did not prevent the chest wall skin metastases.
How is that possible?
The radiation doses required to definitively kill every single microscopic cell dragged through the tract would cause unacceptable damage to the surrounding healthy skin and bone. And at the tolerable doses they were using, it simply wasn't effective.
So they were giving patients radiation damage for no actual clinical benefit.
Exactly. It overturned decades of standard practice. The guidelines now explicitly recommend against routine prophylactic radiation of these tracts.
That's incredible.
It really is a testament to the medical community's willingness to abandon old, logical-sounding habits the moment rigorous data proves them ineffective.
Okay, so if we are doing less radical surgery and we are skipping ineffective radiation, how do we actually fight the cancer for the vast majority of patients? Because many people, due to catching the disease too late, simply cannot have surgery at all.
That leads us to the systemic therapies, the drugs that travel through the entire bloodstream to chase the cancer down wherever it is.
Historically, the standard of care was chemotherapy, specifically a combination of a platinum-based drug and a drug called pemetrexed.
And that regimen was notoriously harsh. Patients required strict supplementation with folic acid and vitamin B12 just to protect their healthy cells and make the toxicity of the pemetrexed survivable.
And later on, the MAPS trial showed that adding bevacizumab, which is a drug that starves the tumor by preventing it from growing new blood vessels, improved overall survival.
Yes, that was a step forward.
But the massive landscape-altering breakthrough, the one that completely rewrote the ESMO guidelines for first-line treatment, was the Checkmate 743 trial.
This was a watershed moment for unresectable mesothelioma.
This is the shift to immunotherapy, first-line use of two drugs, nivolumab and ipilimumab. Here's where it gets really interesting.
How so?
Think about it like this. Chemotherapy is a poison. It kills fast-growing cells, but it damages the healthy tissues in the process. It's like a broad-spectrum weed killer that damages the lawn. The cancer, meanwhile, acts like a hacker. It exploits vulnerabilities in the body's immune system, essentially turning off the internal alarms so the white blood cells ignore the tumor. Immunotherapy drugs like nivolumab and ipilimumab act like a software patch. They block the cancer's ability to hide, turning the alarm system back on so the patient's own immune system recognizes the tumor and attacks it.
That is a highly accurate way to visualize dual immune checkpoint blockade. Ipilimumab blocks a pathway called CTLA-4, and nivolumab blocks the PD-1 pathway.
And what were the results?
The survival numbers from Checkmate 743 were unprecedented for this disease. At 3 years of follow-up, 23% of patients on the immunotherapy combination were still alive, compared to only 15% on standard chemotherapy.
Wow. And the benefit was incredibly pronounced for patients with the non-epithelioid subtypes, right?
Yes, the sarcomatoid and biphasic subtypes are traditionally the most aggressive and the most resistant to chemotherapy, but they responded beautifully to the immunotherapy. But, this raises an important question about how we select patients for these powerful, expensive drugs.
Right, because in other cancers, like melanoma or lung cancer, oncologists test the tumor first. They look at the tumor mutational burden, or how much of a specific protein called PDL1 the tumor expresses. If the numbers are high, you get immunotherapy. If they are low, you don't.
Exactly. But the ESMO guideline for mesothelioma is adamant. Do not use those biomarkers to withhold treatment here.
Why is mesothelioma different? Why does it respond, even if those markers are low?
Because the tumor microenvironment in pleural mesothelioma is uniquely complex. It is highly inflammatory, driven by that decades-long asbestos irritation.
So the immune cells are already there, just suppressed.
Exactly. The clinical data in Checkmate 743 clearly show that the survival benefit of the immunotherapy exists regardless of PDL1 expression levels. Every eligible patient with unresectable disease should be considered for this therapy period.
That's huge. It removes a massive barrier to patient access.
It really does.
Before we wrap up, I want to touch on one incredibly counterintuitive note from the guidelines regarding supportive care. You would assume that for a disease as heavy and complex as mesothelioma, you would want palliative care experts involved on day one, right at diagnosis.
It seems perfectly logical to wrap the patient in supportive care immediately. But a large randomized trial looked at this specific question, and they found that early peri-diagnostic referral to specialist palliative care did not actually improve the patient's overall quality of life.
Wait, why wouldn't early help be better?
Because medicalizing a patient too early can actually spike their anxiety. When a patient is newly diagnosed, but perhaps not yet experiencing severe symptoms, constantly bringing them into the clinic to discuss palliative measures forces them to focus entirely on their illness rather than living their life.
Oh, I see.
The data suggests that these intensive supportive resources are best deployed later, timed exactly to when the physical symptoms actually arise and require intervention.
It is all about treating the human being, not just the scam. Well, we have covered an immense amount of ground today. We started with the physical mechanics of asbestos fibers and their 40-year lag time. We explored the microscopic detective work of finding missing BAP1 genes using chemical stains.
And we tracked the vital physiological shift away from lung-removing EPP surgeries toward lung-sparing decortication.
Right. And finally, we unpacked the Checkmate 743 trial, where immunotherapy acts as a software patch to let the body's own immune system hunt down the cancer.
It is a profound testament to how far medical science has evolved, analyzing its own failures and following the data to better outcomes. But if I can leave you with one final, broader thought to consider.
Please do.
While we are discovering these highly sophisticated targeted treatments, we cannot forget the epidemiology we discussed at the beginning.
The continuing asbestos use.
Yes. Asbestos use is not a relic of the past. It is currently rising in rapidly industrializing developing nations of parts of Central Asia. Because of that inflexible 40-year biological lag time between exposure and cellular mutation, the timer's just starting right now for a whole new generation of workers. Which leaves us with a very sobering question to ponder. How will the global health system handle a fully preventable industrial epidemic when that time bomb crests again in the 2060s?
It is a heavy thought, but an essential reality to keep in mind. The timer is still ticking. Thank you for joining us on this deep dive into the source material. We hope it brought some clarity to the murky diagnostic waters.